to be panelists. Okay, so the presentation will be recorded, as you have heard, archived in the CD2H YouTube channel. As always, use Q&A and or chat to post questions. Next slide, please. So first, the presentations in the near future. A fellow with a somewhat familiar first name, Joel Gagnier, will be presenting musculoskeletal associated post-acute sequelae of SARS-CoV-2 December 5th. December 12th, malnutrition and COVID-19 outcomes by Corinne Hansen and Jana Ponce. And then December 19th, TBD, and we're off the 26th and the 2nd, which seems wise. Next slide, please. So this is really, the enclave, roughly the same size since I saw it last 3 weeks ago, about 6.5 million COVID patients. So next slide, please. So this is going to be really interesting and actually very informative talk for a lot of folks, including myself, in that this involves a description of work that's been done to both very interesting research, but also leveraging N3C resources for an R01 in the social determinants of health, HIV, COVID space. And we have a number of people who are going to be presenting. And so I look forward to it. And who's the first presenter? Is it Rena Patel?
Yes. Yeah.
Great. Okay.
So much. I am going to share my screen. Let me just make sure I have the right presentation view. Okay. Before we get started, can I just make sure? Okay, Jessica Islam, Jing-sun, Jing, your name I think shows up as Jessica Islam. I'm not sure how that happened, but if you can change your name, and then more importantly, if we can get Jessica Islam added as a panelist, that would be great.
Sorry about that.
I think, sorry about that. I might log out and then log back in again. Oh, I see Jessica actually getting on board right now.
Okay, okay.
I might leave and return real quick. Yep.
Great.
Okay, thank you so much, Joel and Torsini and the rest of the N3C community for asking us to present today. This is really meant to be interactive. We want to share our thoughts and lessons we've learned and really enable others to think about how to write their own individual grants to leverage N3C resources. So that's the entire context. Please, discussion points are welcome even throughout if you want to, but certainly at the end, we'll look forward to making this highly discussive. And this is a really large group effort with all the people who are listed here. And I want to acknowledge that Elaine Hill cannot make the presentation herself today, but she's provided some information. Unlike saving the thank yous for the end, I'm actually going to put them at the very beginning because I really want to acknowledge that, like so much in N3C, this is really team science. All of the people you're seeing as co-panelists presenting today, as well as others who are not presenting today at all, including Dong Mai and others. So really want to thank all the collaborators. And there's a larger group, the N3C immunosuppressed compromised domain team and the HIV subdomain team, which is housed under this larger umbrella team, which include people such as Amy Olax, Eric Hurwitz, Jared Unzel, Nada Fadul, Ken Wilkins, and more, many of whom work in other domain teams, and you may be on the call or work with them. Thank you so much. We also want to acknowledge N3C social determinants of health domain team leads, particularly Charisse and Jimmy, who have started working with us in the last couple months. N3C leadership and support team who supported us throughout the process of applying for the grant. And now that we've obtained it, supporting us as we implement the work as well. I also want to acknowledge the University of Washington Fred Hutch Center for AIDS Research. You will see later we've added a community engagement dimension to this work, and particularly want to acknowledge Stefan Wallace and Rahel Schwartz in this work, and you'll hear more about it shortly. And lastly, Shukri Hassan, the research coordinator at UW, who's been working with all of us. So for the next 30 or so minutes, here is the outline that we hope to talk about is the overview of the R01, its specific aims, and our community engagement supplement. We'll go through some of the administrative details of the grant, and then we'll spend much more time on the feasibility and plans for each aim, some of the tips we would like to offer on leveraging N3C, and then acknowledgements, and spend as much time on discussion as we can. So for an overview, it was prompted by a notice of special information, a Nosyk put out by the NIH that wanted to look at when the two epidemics or pandemics collides, a collision of COVID-19 with existing HIV. And we chose to work in the space that showed that racial ethnic disparities worsen in both, and that the COVID pandemic really simply exacerbated those disparities that used to exist in HIV. For example, Black adults only account for 10 to 12% of the US adult population, yet 42 to 45% of HIV diagnoses and deaths among people living with HIV. So really disproportionate epidemic. People living with HIV, as you will see later with Jessica, have higher risk of poorer COVID-19 outcomes, and those are worse among Black and Latinx than white individuals. So what we hypothesized in our work is that these racialized disparities are likely driven by structural racism and social determinants of health. And we said, what better place to work in this than within N3C? In N3C, we have the largest cohort of people living with HIV with COVID-19 outcomes. When we submitted this grant, when we were working on it, December 2021, so almost a year ago, we had phenotyped more than 77,000 individuals as people living with HIV. That has grown over time. N3C has granular clinical individual level data, but the beauty is that can be merged with area level measures, and we wanted to capitalize on that. And through this work, what we proposed to do was look at bidirectional impact of existing HIV on COVID and COVID on HIV. So here's a summary of our first aim. And I do want to share this here because a few people have approached us to understand a little more about exactly what our aims were and how we wrote this grant. So I have a lot of the language right here. Aim 1, we called it our HIV outcomes. Aim to identify multi-level social determinants of racial ethnic disparities in HIV outcomes during the COVID pandemic. And, you know, we were, because of there are over 120 social determinants of health variables that are currently already available in N3C. Because of that amazing depth of data, we said we would use rigorous machine learning and statistical learning to first identify those predictors most associated with HIV outcomes, and then conduct a mediation analysis with multi-level modeling. And our hypotheses were that Black and Latinx persons living with HIV would have worse HIV outcomes than white persons, and that these would be mediated by specific social determinants of health pathways. Aim 2 looked at COVID outcomes, and you'll hear more details about this, but it was to sort of understand the opposite relationship where independently and in aggregation, what impact social determinants of health and clinical characteristics would have on immune dysfunction resulting with COVID-19 infections and outcomes and vaccine effectiveness, and to quantify this at a US population level by race ethnicity. So we were going to leverage some of the same machine learning statistical learning work in AIM1 here in AIM2, and then look at specific markers of HIV immune dysfunction and COVID outcomes such as hospitalization and post-vaccination breakthrough infections, and calculate population attributable fraction for COVID-19 outcomes for HIV by race ethnicity, and a similar hypothesis here as well. The third aim we call our HIV epidemic modeling was to quantify the impact of the COVID pandemic on the HIV epidemic. And in the US, we have something called the Ending the HIV Epidemic, EHE initiative, which is a federal initiative to prioritize funding and activities in jurisdictions that have a large impact on the HIV epidemic in the US. And so you'll hear more from my colleague Bohdan later about estimating the treatment prevention outcomes by race ethnicity pre-post COVID within N3C. So we would get this empiric data from N3C, and then their group would use this to enhance their dynamic compartmentalized transmission model to ascertain the impact of COVID-19 on EHE jurisdictions. And so, the pitch we made in the grant was really that all three of these aims centered around racial equity, and that work in this area would help address interventions that should function at higher orders outside of just the individual levels, such as structural or social levels to address HIV disparities. I'll take one moment here to talk about the additional work we've added to this, which is funded through the Center for AIDS Research here at UW Fred Hutch, and we call it our community engagement dimension. And the pitch here was that big data science efforts really have a lot to offer for understanding social determinants of health and their impact on these racialized inequities, particularly in HIV and COVID, but that no work to date has really added community engagement component to big data efforts in HIV, and certainly not in N3C. So we really wanted to leverage this opportunity to do that, and to do so through mutually beneficial community engagement processes that built on two main bodies of work. One is community-based participatory research, CBPR, which some of you may be familiar with. And the second is a good participatory principles, GPP guidelines, which my colleague Stefan Wallace has worked a lot in the HIV Prevention Trials Network. And so we were going to take those lessons learned in those two spaces and bring it to this work in big data science. The overall objective, I would say, is to improve the ability of both community partners and researchers to co-create scientific agendas in a more meaningful way to ultimately shape the next generation of EHE interventions. And so our goal was to formalize and build up community partnership component to our broader work in N3C, which you have heard of and will in the next few minutes, and to really ensure that there is representation and belonging from priority populations, in this case, affected by an elevated risk for or living with HIV. And so we were going to take these specific measures. One, we're going to provide training to community leader, who is Rahel Schwartz, to serve as an NPI in the project. She's the director of health equity at YMCA of Greater Seattle, where University of Washington is based, including myself and Stefan Wallace. Second, we're identifying and recruiting a cohort of 10 community members to serve on our scientific advisory board. I'm really excited to say that we've gone through this phase. Number 3 was identifying recruiting 6 community-based organizations to help us assist with focus group discussions. And we've done that as well. And we're planning to start our focus groups in the new year. Training of this cohort of community members and community-based partners to develop a policy brief based on the first analysis. We haven't begun our first analysis, so we're far from this activity. And then lastly, utilizing the community intersections in the project to identify gaps and develop plans for interventions that I was saying at the larger levels to respond to the EHE efforts. So these are the 3 aims of that community engagement supplement, which was started in August or September 2022, that we would co-create the scientific agenda and analytic model development parameterization alongside these community members. And so we're working on the focus groups. We are hosting our first meeting in December. The second aim was to engage our partners in interpretation of results and dissemination. So one of the ways we hope to do this is through a policy brief that I mentioned and hosting an end of the year workshop and what we're calling member check to really see if our findings are resonating with our community members. And to lastly, evaluate this engagement process itself and find ways to improve on that. And so now I'll shift to the administrative details. There should be few things that we applied for an R01 funded by the NIMH. Our program officer is Lori Scott Sheldon, who I want to give a special shout out to during this talk, who really helped us strategize on what would resonate best with NIMH funding priorities. It's a 5-year award. It started in July. And that's the funding amount. University of Washington is the prime institution, and we have the 5 subcontracts represented by individuals who will be talking today. And a little bit on the timeline to help think about how this project worked out and how it may support work that you are considering. So the Nosyk was released in June 2022. And we quickly developed some draft aims and met with the POs because right away we felt we were really well positioned to respond. In July through September, we finalized aims, identified the team members, we began the fiscal administrative components. And a lot of this work was asynchronously via shared Google Drives, not unlike much of N3C. But we did have 1 or 2 Zoom meetings to work synchronously. And then November, December, rubber hit the road. We met 1 or 2 times as the larger group. You'll see here to finalize aims and get the subcontract submitted, and then submitted the grant in first week of January over the Christmas holidays. I really want to thank everyone working on this project again for that pitch, which is a lot to ask for December. We were really fortunate and blessed to be scored at 1st percentile, and our funding began this July. I am now going to head over to hand this over to Jessica Islam to talk about feasibility and plans for the first aim. Thank you, Jessica.
Sure. Thanks, Rena, for the overview. So I'm going to talk a little bit about AIM 1. So Rena presented the exact text for AIM 1, but just to go a little bit in more detail. So as Rena mentioned, AIM 1 is focused on our HIV specific outcomes, and those include things like viral suppression, CD4 count, overall hospitalization, basically things that are occurring that are pertinent to HIV specific outcomes and care. But this was specific to the COVID-19 pandemic, which is the strength of the N3C. And here I'm providing what was our conceptual diagram for AIM 1 that was included in the grant. And overall, what we are hypothesizing based to carry out AIM 1 is based on the racial and ethnic inequities that we've observed, leveraging N3C and COVID-19 related outcomes. Our outcome that we've been able to analyze or look at so far in the context of racial ethnic inequities was COVID-19 test positivity. And in that analysis or undertaking, we found that Latinx and non-Hispanic Black adults were more likely to be positive for COVID-19 compared to their non-Hispanic white counterparts. Here is a nice graphic that is summarizing that specific work and that specific outcome. It was published in early 2022. And basically this provided kind of the formative basis and foundation of AIM 1. And it provided the rationale and the preliminary work necessary to establish the fact that first there are inequities in both HIV and COVID-19 related outcomes by race ethnicity. And as we all know, race ethnicity is not, the disparities observed by race ethnicity are not necessarily biological. Rather, they are manifested based on structural and social factors that impact populations where racial and ethnic inequities arise. And therefore, that provided us the foundation to say, well, we are interested in delineating what are the social structures that lead to these racial and ethnic inequities that we've observed based on these preliminary analyses. And that was kind of the impetus for both AIM 1 and 2, and really led to strengthening our research proposal. I think we can go to the next slide. And so we had the information related to race and ethnicity, and we know that race and ethnic inequities manifest due to social structures that disadvantage vulnerable populations and that are measured through social determinants of health. And part of the rationale as to why we as a group were, best fitted or best suited to be able to carry out this important research was also manifested in this preliminary work conducted by folks on our team, looking at other social determinants of health, specifically historical housing segregation on a different outcome, preterm birth, but provided evidence of our collaborative or combined expertise in looking at social determinants of health from a structural perspective, which was really important to kind of provide in the grant in order to be able to say that we are the best suited team to be able to do this work. So this was work led by Dr. Elaine Hill and as well as Rena, using in the I believe it's called the pregnancy outcome domain, and they specifically looked at the role of historical housing segregation, which they measured here using the Homeowners Loan Corporation redlining data. And that is an important social determinant of health that we also included as one of our measures of interest in our specific proposal. And based on and leveraging N3C and looking at this specific exposure, they did find that there was an increased risk for preterm births for areas with the worst or I guess the most severe historical housing segregation, or also known as redlining, within Rochester, New York. And they also found that the same areas had increased risk for COVID-19 infection in 2020. So important preliminary information that really provided the background necessary to say that we as a team were both had the expertise in order to be able to conduct the work that we were proposing. Next slide. I'll hand it over to Dr. Sandra Safo, who's going to talk a little bit about the machine learning aspect of our research proposal.
Sure, thanks, Jessica. So we had done work that we're interested in understanding how risk factors for severe COVID affect people with HIV. So there had been work done in the literature looking at COVID, looking at HIV, effect of HIV on COVID severity, but the other direction wasn't so clear. So this was a thesis work done by one student called Miranda working with me. So we used machine learning and statistical learning methods to rigorously identify risk factors for severe COVID-19 in the general population. And some of the factors that we identified have been identified in the literature before, so sort of validating the things that were already existing in the literature, and some of them were also somewhat novel that we want to explore further. So once we identified these risk factors, we then proceeded within the HIV population, looking at how these risk factors impact outcome when we only consider those with HIV. And we did find that, interestingly, we did find that sodium was significantly associated with increased odds of severe COVID among Black versus other patients. So we believe that this provided the grant, provided us with preliminary data just to say that we have the expertise to conduct rigorous machine learning and statistical learning methods for the aims proposed. So we will be using similar ideas in this work to identify SDoH variables that predict HIV outcomes during the COVID-19 pandemic, and then proceed with our mediation analysis.
So back to me. So really quickly, we, currently, as our focus on AIM-1 progresses, we are gearing up, the analytic approaches that we're going to be leveraging, and as a first step to kind of orient ourselves to the social determinants of health data that are documented at N3C, we are focusing on individual level social determinants of health to examine racial and ethnic, inequities in HIV specific outcomes pre and post the pandemic as a measure of social determinants of health pathways that may be leading to these inequities. We're working with the social determinants of health domain team leads, Drs. Sharice Madlick-Brown and Jimmy Fong. They are really supporting us in getting this work off the ground, given their expertise in and contribution really in leading the way and ingesting these important data into the data set. And so we're getting our hands dirty, figuring this out as a first step. And our next steps will involve, after this first analysis is kind of taken place, our next approach will get to the area level social determinants of health that would require the more rigorous analytic approaches that were described by Dr. Safo, focused on machine learning and identifying predictors based on the SDoH frameworks that we've proposed in our NIH grant proposal. So that's where we are right now. Happy to take any questions regarding our experiences in translating the proposal to actual analyses or anything related to AIM-1 specifically. Hearing none, I will hand it over to folks leading AIM-2.
So thank you so much for the opportunity to present. So AIM-2, I am Dr. Jing, and along with Dr. Jennifer Ross, we are going to co-leading the AIM-2. So in AIM-2, we plan to quantify the independent and aggregated impact of the social determinant of health and clinical characteristic on HIV immune dysfunction for COVID-19 infection, including the disease severity and vaccine effectiveness. And additionally, we plan to quantify the differential impact of HIV on the COVID-19 outcome by racial ethnicity differences. And then, so as the AIM-1 team, as well as Dr. Patel has described very nicely, that the impact of social determinant of health during the COVID-19 pandemic in the HIV population, as we also learn from the other literature as well as our own work, that this is really a bidirectional impact, while there is the impact on the HIV disease severity, there is also the HIV disease severity also impacting the COVID-19 outcome. And in previous study we conduct, we showed that the people with HIV appear to be at higher risk of worse COVID-19 outcome than the people without HIV. But the complex relationship between the social determinant of health, HIV disease severity, as well as the COVID-19 outcome has not been well described. And this health disparity produced by the social determinant of health has been observed throughout the US during the HIV epidemic, where patients with the lower social determinant of health and racial minority is likely to have poor antiretroviral therapy adherence, high risk of HIV virological failure, and suboptimal immune recovery. And all of these are potentially linked to the COVID-19 disease severity. And although the rest of the society is returned to normal life after the COVID-19 vaccine and immunity after they recover from an infection, people with HIV, especially those have poor access to care and low socioeconomic status, may continue face challenge in this ongoing pandemic. Next slide. So to support these hypotheses and theory, one of our previous work conducted in the early pandemic showed that people with HIV have a higher risk of more severe COVID-19 outcome compared to people without HIV. Specifically compared to people without immune dysfunction, we observed that HIV infection is associated with about 20 to 40% higher risk of requiring invasive ventilation and COVID-19 related death after contrasting COVID-19. And furthermore, the risk of COVID-19 related hospitalization, invasive ventilation, and related death are further driven by their CD4 cell count, as well as the HIV viral load. And it shows a dose-dependent relationship based on the disease severity. And these findings highlight the importance of managing HIV disease severity and immune recovery to reduce the severe COVID outcome among people with HIV. And aside from higher risk of severe COVID outcome, our other study also showed that people with HIV have a higher risk of COVID-19 breakthrough infection after their flu vaccination than people without immune dysfunction. And specifically, people with HIV HIV infection is associated with 33% increased risk of having breakthrough infection compared to people without immune dysfunction. And although the COVID-19 vaccine does help reduce the severe COVID outcome, including the invasive ventilation and death among people with HIV, this risk for the HIV patient is still comparable to that among the general population without vaccination. And these results also highlight the needs for a continued monitoring and prevention for infection among people with HIV during further surge and the the immune escape of the viruses. So these studies did lay out a lot of groundwork for us to developing our AIM2. So I'm going to talk about AIM2A next step. Currently, we are focused on understanding the individual level social determinant of health and the race ethnicity disparity in the HIV disease severity and comorbidity burden. So these are largely collaborating with the AIM1 team, including Dr. Islam and Safo and Elaine Hill and Dr. Domaili. And I'm going to hand it to Dr. Jennifer Ross.
Thank you. So as has been discussed, I'm part of the AIM2, looking at HIV impacts on COVID. And AIM2B is really bringing together the N3C data resource with another large-scale data resource for HIV outcomes across the US called AIDSview. So in this part of the study, we will quantify the disproportionate impacts of HIV on COVID-19 outcomes within groups by race and ethnicity in the US. And we will do this using a population attributable fraction approach, looking at the exposure to different levels of HIV disease severity, as well as HIV prevalence in the population at different geographic areas, and then utilize N3C data to look at the relative risk of COVID outcomes between different levels of HIV disease severity. So at this stage in the project, as I'm new to N3C, I'm getting to know the N3C COVID data as well as the HIV data, which we will use to estimate the impact of HIV disease severity on COVID-19 outcomes, including the CD4 category and viral suppression frequency. And then also getting to know a key data source for this AIM, which is the AIDS View summaries of CDC data on HIV viral suppression, which is available by racial and ethnic groups for each state, and actually at even further levels of geographic disaggregation. So this graphic here is from the AIDS View database, showing how surveillance data are made available both in tabular format and then visualized in map format as well, at different levels of geographic aggregation that we can then bring together with the relative risk estimates from the N3C analysis. On to Bohdan for AIM-3.
Thank you, and I'm just trying to figure out how to advance my slides. I'm not sure I can. Hopefully, somebody can manage that for me. Thank you. So AIM-3 is a little bit different. AIM-3 takes advantage of a project that's been going on for some time. So the localized economic modeling study is something we devised back in 2016. So the concept was really informed by, at that time, a lot of the work that PEPFAR was doing in providing regionalized, localized responses to acknowledge differences across geographic regions in their work in Africa. And later, that work that PEPFAR was doing informed the US's ending the HIV epidemic response. So EHE, if you haven't heard of it, it is a very ambitious, some people would say too ambitious, plan to reduce new diagnoses, new infections by 90% from 2020 to 2030. And the strategy is sort of contingent on, it acknowledges the geographic disparities and the fact that most of the new diagnoses are happening in 48 counties and a few states with lots of rural transmission. So we want to use this model. Of course, we have been working on this for some time. The COVID pandemic hit, and a lot of our sort of tailored recommendations for each of the first 6 cities that we were working on were obviously disrupted by the COVID pandemic. And we had made estimates on what impact the pandemic might have at the outset based on some assumed changes in behavior and early results on disruptions in access to care. When I heard of N3C and I heard of the data that you had, I thought this is perfect, and it would be a perfect fit to integrate it within our modeling effort. Okay, so our goal was to quantify the impact of the pandemic on treatment and prevention outcomes by race ethnicity at the population level for the national EHE priority jurisdictions. Okay, next slide, please. So here's a bit more background on this study. As I say, it's been we've been doing this since 2016. We were recently renewed for another 5 years. So a lot of our work is a lot of our round 1 work, I'll say, is already out there. So we outlined our scientific case. We published studies on our evidence synthesis, as well as some work that we did with the HIV research network. So that was papers 3 and 4. These data analyses were direct inputs into our model. Okay, and I see N3C filling a similar role. It gives us a unique insight that we really can't get from any other data set. We then sort of published our a real deep dive on our model, the calibration and validation of this model, described what the status quo would be, and made the case that we can't continue on in the same way that we have, because we aren't simply naturally going to meet the EHA standards. We need a lot more investment, a lot more focused effort. We then came up with our, we described 16 evidence-based interventions that we would consider in all individually and in combination for each of the 6 cities that we focused on initially. We put those all together in publication 8, and then we really, publication 9 is very similar to 8, except we allowed for equity-oriented strategies. So instead of assuming that the balance of access to treatment and prevention strategies wouldn't change, we considered scenarios where access would be increased in communities that would need it most, and that was a big deal. That, you know, it really highlights that EHE is simply impossible without an equity-oriented approach. So racial inequities in access to care that's a central focus for this project. Next slide, please. So this is a high-level schematic of our model. As I said, it's a dynamic compartmental model. So we're breaking up the entire population, the adult population, for initially it was 6 cities. We're now adapting and expanding to all EHE counties and states. But we're using this basic setup. And you can see we are accounting for race, ethnicity, HIV risk behavior, sex, sexual risk, levels of sexual risk behavior, and then access to different services. So this basic model allows us to consider not just one intervention, but all reasonable interventions that we can pick out across the 4 pillars of the EHE strategy. And the 4 are treat, diagnose, prevent, and respond to geographic clusters. Next slide, please. So on the top left, this is our initial paper that came out very soon after the pandemic hit. And, you know, at that time, we didn't know what kind of impact we should expect on the HIV epidemic. And we made the case that, well, you know what, we expect access to services to be reduced, but if behavior changes, if there is less risk behavior, that might offset some of those reductions in access. You know, interestingly, since this has hit, you know, it's been very clear to us that HIV testing has come down pretty dramatically. In 2020, even 2021, we've been trending down since 2017. The number of HIV tests that we administer, at least the ones that the CDC funds. And so that gave us a false sense of security. It looked in 2020 that new diagnoses had come down, but really it was a matter of detection. We just weren't testing as much, so we weren't detecting as much infection. And I can tell you, I think these statistics are still coming out, but 2021, you know, we saw a big rebound. And at least in the state of Florida, we know that infections are higher in 2021 than they were in 2019. So we're still in a challenging predicament. And you know what that tells us, at least for the state of Florida, again, that the reductions in access overcame whatever changes in behavior that we might have seen. The bottom right article is our sort of distributional, we're calling it a distributional cost effectiveness analysis. So we think, you know, it's the first DCEA that's been done in an infectious disease context. And what I think is important about it is that, you know, not only is an equity-oriented strategy, not only will it provide greater impact in terms of not just new infections averted, but overall health gains, it's actually going to be less costly in the long run to do this. So there's no compromise on value in trying to execute an equity-oriented response. We made the case with our simulation model that really the HIV epidemic in the US is really driven by race. and disparities in access, not just disparities in access to care, but also racially segregated sexual networks. And these two factors, it's really two factors feeding into one another. The fact that Black MSM almost exclusively mixed with other Black MSM, and the fact that access to care in that community is so low, that is a big driving force of the HIV epidemic today, and it's a point that we really need to focus on. Next slide, please. So again, we initially looked at 6 big cities in the US, and that was really just a proof of concept. But keep in mind, those 6 were chosen before EHE was announced. And so now that it has been announced, it's a broader geographic scope, and we're trying to match that as best as we can. So our target is 57 jurisdictions. That's including the 48 urban counties plus 7 states with large rural transmission rates. And data is, the underlying data that we plug into our model is just as important as anything else we do afterwards, in terms of how we structure it and how we build it up. So for us to be able to access N3C is really great. We're really excited about it. You can see that we have an agreement to use NA Accord data. So that is a cohort study, a multi-site cohorts collaboration across the US. We use a lot of CDC data. AIDSview is a close partner. You heard them before. So the model itself is very data hungry, and the better quality inputs that we can put into it, I think the better outputs that we'll get out. Next slide. Oh, and just to kind of conclude that, now that we have this data collected, we can really specifically estimate the impact of COVID on the HIV epidemic as a whole. So again, not just changes in incidence brought about by the COVID-19 pandemic, but also overall health gains and losses, right, resulting from COVID-19 infection from people living with HIV. So it gives us our best chance at putting an estimate on this point, and I think it's a really important factor we need to consider moving forward. So thanks.
Thank you, everyone. We're going to shift to some of the more generic points about this presentation. One, tips on leveraging N3C. And so what I wanted to share from what we as a team gained from this. So, we had a letter of support from N3C leadership. Melissa is on the call today. She was highly supportive of us putting this grant forward. And she facilitated us being able to obtain many of the other documents that make the grant submission, such as facilities and resources, data and resource sharing, and protection of human subjects. So I would say the leadership and the support team were really helpful in giving us as much of this type of documentation that we could easily adapt for our work. And a special shout out to Julie McMurray, who is a magician when it comes to graphics. I promised her I would not volunteer her for more work in this presentation. And just to wrap up our time, again, the same acknowledgements. And since we do have a little bit of time, this is just a little plug for the immunosuppressed compromised domain team that I am so fortunate to be able to co-lead with Amy Olox, who is at VCU. There's the small, tiny link for you to join our meetings. And I'm going to skip some of these other slides I put in here and jump to discussion and question and answer session. This is an honest approach from us to say, how can we help? We've learned a few lessons that we're eager to share with the rest of N3C community. We would love to hear what funding mechanisms you've considered in the past or are considering for the near future. What ideas do you have? if you have already applied for funding leveraging N3C, what your experience has been like, and how could we, as a team, collaborate with you to support your proposals? So really open to questions and discussion right now. Thank you.
Well, thank you. This is a remarkable presentation, and I can see why you got a 1%. This is extraordinarily impressive. Questions? So I have one to start out, which is so maybe folks talk to us about your experience with N3C SDoH data versus, or I should say, combined with other data sources. Obviously, N3C, primarily is, as we know, an aggregation of data from health systems where the SDoH data may not be the highest priority, for each health system. And obviously your other data sources are more focused on this. Maybe if somebody could talk about how you melded these data sources, because obviously you did, in order to get sort of optimize your SDoH resolution.
Thank you, Joel. I think you've asked a few questions in that one question. And what I'm going to do is I wanted to treat it as a panel to invite my colleagues to comment here as well. So Jessica, particularly with you starting to get your hands dirty with SDoH data within N3C, I'm hoping you can comment further. What I will say is that, so there are other cohorts within the US that track the HIV epidemic. NA Accord is one that Bohdan specifically mentioned, and that leverages the IDEA consortium. It's a global consortium, and there's a North American site, and that's the North American Accord one. I lack clarity on the exact numbers of individuals, but there are very few individuals with COVID in that data set compared to what we can offer from N3C side. So that's where, we have that ability, and that the NE Accord data set does have some social determinants of health information, such as housing insecurity. There's another cohort called CNICS in the HIV world that's US based, and has some measures, but none are as interesting, as powerful as what we can do within N3C with area level linkages. So because we have zip code data, you can pose a question about air pollution quality index, and we can try to answer that. Does that influence, HIV outcomes, for example? So I think there are some unique strengths and weaknesses to probably every data set. And what we're trying to do here is leverage what we perceive as the strengths within N3C. That being said, when you get your hands dirty, you find out more. So Jessica, can I invite you to comment more about SDoH data and data quality within N3C?
Yeah, so like I mentioned in those my slides, we're taking a first stab at kind of looking into individual level social determinants of health. And when I say individual level, I mean factors that are measured or captured within N3C that are specific to the patient that is captured in N3C, rather than area level, which is more context specific, and as Rena mentioned, linked in through publicly available data sets based on availability of zip code. So these these individual level SDoH have been kind of ingested and characterized within N3C, leveraging existing phenotypes that have been, created in other EHR specific resources. A lot of them are coming out of folks from in California who have done a lot of this work trying to integrate SDoH into EMRs in order to be able to risk-based stratification of folks based on any like contextual individual level social determinants of health to kind of prioritize who is more followed up with for care and things like that, like basic strategies. So so these phenotypes create these, measures within N3C and within other EHRs, and they rely on existing data within N3C for that specific patient. And given the heterogeneity across the different sites that are kind of pouring data into the big N3C resource, there is definitely differences across sites in terms of missingness, in terms of what is captured, relevant to SDoH based on the specific infrastructure of that specific institution and their priorities and what they are capturing within their EHR. So there are certain sites where the majority of these data are coming from when we're thinking about individual level SDoH. So that kind of, cuts the data already. And then there's missingness within each individual level patient based on what's captured or not. So there's certainly nuances in thinking about how to leverage N3C for individual level SDoH work, given, like I mentioned, it's coming from a certain number of sites. So we're kind of losing the national representative, or like one of the biggest strengths of N3C, given that it's coming from all these different areas of the country. We're starting to lose that given regional differences in prioritization of capturing SDoH within electronic health records. And then we're also kind of losing, data based on what is captured for specific patients. Oh, and another thing, it's really interesting to like see when SDoH became important to different like health systems and different health structures, because there's a very obvious like demarcation of when these data are starting to arise in N3C. And because we initially thought we would do like a pre and post COVID data analysis, it's not going to happen because pre-COVID SDoH data are like not there. They're basically not there. It's very limited. So it just kind of is really interesting, and I think deserves, its own like kind of like commentary on how SDoH really became prioritized and came to the forefront during the pandemic, and that is really manifested in the data resources that are available to researchers, using things like N3C and other big EHR data sets. So yeah, those are just a couple of thoughts that come to the forefront. That
great thoughts. No, I appreciate it. And your comment about the increased prevalence of SDoH and N3C over time, that really is fascinating. And I really do think warrants a study, because that's obviously been a huge phase shift. And N3C is in a great position actually to document that over time, because sure, I mean, in the 2019 timeframe, or even when we got started with N3C, it was really sparse. So I mean, I wasn't at the forefront by any means of that, but it was clear that it was tough to get a lot of information, and obviously it's improved. So no, thank you. So there was a question which was answered, but I think it's of a lot of general interest. Joseph Agar asked, when utilizing N3C in your proposal, is there a need to make a request to use N3C as part of your proposal? Do you need to receive a letter of support from N3C confirming your access to the data? And Rena, do you want to answer? And then I guess there was a pointer to Melissa as the more definitive answer.
Yeah. So no, Joseph and others, as far as I'm aware, there isn't a formal process within N3C to say, hey, we want to put in a grant that uses N3C data. Do we even have permission to put forward this grant? I don't know that that formal process exists. It didn't when we worked on this. So that's where I was pointing at N3C leadership to say if it has changed. Now, as with everything else in N3C, obviously for preliminary data, we wanted to show some of the work we've done in N3C. So we would do the data download request and get those approvals before putting them into the grant document. And then, as I mentioned in the written response, we did reach out early to Melissa, Ken, and I'm blanking on the person at Hopkins to say, we're interested in this grant. Would you be willing to write us a letter of support? And they drafted a very strong letter. But I welcome any other related questions, or Joseph, if you have any follow-up points on that.
So no, great. So this is, yeah, I don't think Melissa's on it at the moment. And I can't really answer her, but I'm sure what you're saying is right. Well, this was incredibly impressive. We're a little over time, but an inspiration for all of us and an incredibly exciting project. So thank you very much for presenting, and have a good week.
Thank you.
Thank you.
Take care.
Thank you.